Hey, good morning, everyone. I'm your host, Vic Senese. Welcome to UroNurse. We meet every Saturday at 9 a.m. Central Time. If you're watching us on YouTube, LinkedIn, or Facebook, welcome to the show. For you YouTube people out there, just hit that subscribe button. We're now at 598 subscribers. I looked at it this morning. You guys are doing a great job. Our goal is to hit 1,000. 1,000 is a leveling point that YouTube suddenly gives us a little more cred. So keep working on it. If you're new to the show, be sure to check out our website at uronurse.com, where you can find more about the show. Best place to go to learn more about our show. It's also the best place to go to watch all of our past episodes. And hey, we got 66 of those episodes in the bank. Want to listen to us in your car? Great, no problem. We have an audio podcast. It's found on all your favorite listening medias. Just go to our UroNurse Plus area and you'll be able to click any of those boxes and listen any way you want through anyone you want. Just got to notice recently that the Apple podcast is going crazy. So, hey, guys, glad you're enjoying the show. We're also helping out SUNA. SUNA is having a workplace role and compensation survey. If you're an RN and an active member of SUNA, that's all it takes to qualify to fill out that survey. You can go to our website, uronurse.com, and you'll find this little box here, this little QR code. You can either click on it or scan it with your phone and go ahead and fill that survey out. And if you're not getting our newsletter, why not? Every Monday it comes out with lots of valuable information about the show, and it's the best place to also go ahead and find out more about the show. Oh, hey, we just added in Andrea. Sorry. Now you know it's live, right? So, and if you're also live, be sure to put your questions into that Q&A box. Hey, I got a new sponsor for the show, Pathright Medical, a RestoreX product. They started to join us. They're going to be giving a presentation in February, but hey, welcome to the show. And this week, I'm going to be talking about peeking into the world of urinalysis. And we saw her coming in just recently. Let's get all of our experts on the screen. Hey, welcome, everybody. Welcome to the show. Glad to have everybody on board. Andrea, I know you're a little late. Did you find because of a puppy or a dog that you ran into that was stray, did you find the owner?
We did find the owner. I'm so happy. I was taking my dog out this morning and I found a stray dog. He had little burrs all over his face and shaking and covered with dirt. I was so worried. So I brought the dog up to my condo. She drank 2 big bowls of water, sort of warmed up a little bit. And then I realized, hey, this looks like a dog that lives in my building. So we texted the owner. She had been out all night long. I guess she was doing the hiking trails. They're called oak leaf trails here in Wisconsin. They're absolutely beautiful, and they go through all these wooded areas. So I guess something happened. I think she tripped and fell or something, but the leash broke and the dog ran off. And so they actually had the fire department out looking for the dog all night. They had drones and everything because the temperature was below freezing last night.
Yeah.
And so this happened miles ago that the dog got off the leash, and here she is waiting at home for her mom. So we just came upstairs from reuniting Sunny with her mom, and I'm so happy about it.
Oh, great story. Glad you could join us. And why don't you go ahead and introduce yourself since I have you up on screen?
Sure.
I don't think you can top a better story than that one.
You said I need to introduce myself?
Yeah, go ahead and introduce yourself.
Yeah, my name's Andrea Strong. I'm a nurse practitioner. I work in urology in an academic setting. I've been working as a nurse in urology for a long time. I've done inpatient, I've done outpatient. I've been working with SUNA for a long time as well. I'm also the educational director for the Chicago Metro chapter. And I was recently elected to the National Board of Directors. I'm a director at large for SUNA as well. Yeah. So I'm happy to be here.
Hey, great to have you on board. Lace, go ahead and introduce yourself. If you got a story or anything you want to share, feel free to share it.
Good morning, everyone. I'm Lace Heidemann. I'm a nurse here in the state of Iowa, have been a nurse for a long time, most of that time in urology. Currently work at a private practice out in Clive, Iowa. I'm glad that you guys found that dog's owner, and how interesting, right? That it would just go so far and just be waiting at home for its owner. My goodness, that is crazy. I'm glad that you were able to help and get them reunited excited.
All right, great. And of course, I'm Vic Senese. I'm the host of the show, and I'm also the guest speaker for today. I'm going to be the one I said talking about peeking into urology. Not going to share any stories right now because I got some stuff I want to talk to you guys about at the end of the show. So if you're ready, I'm ready. Let's go ahead and bring in our slides. And there we are, peeking into the world of urinalysis. Now, one of the things I was thinking about is that there's a big need out there for people that are new to urology. If you haven't been involved in urology for very long, it's hard to find good places to go for information. And this is one of the things I thought UroNurse could really fill that need. So today I broke this talk into two sections. The first one really is the basic. I think it's the one that most people are running in their office, and it's just the machine or the scanned urinalysis. And then next week we're going to do the microscopy, talk about how to use that microscope if you have one in your office. If you don't, maybe you ought to consider getting one. But so we're going to do the basics. So if you're new to urology, start taking your notes. All right. And gotta remember which buttons to push. There we go. So at its heart, urinalysis is just another tool in our toolbox of lab tests that we can order and perform. Nice thing about urinalysis is it's quick and can be done easily in the doctor's office, especially urology offices where we look at urines all the time. And at its key, what is a urinalysis? Well, it's a laboratory exam looking at the physical, the chemical, and the microscopic properties of urine. Why is this even important? Well, urinalysis can be the very first thing to detect a problem. And a good example of this, and I'm sure it's probably happened to some of you in the audience, where you go ahead and you do a UA on a patient, and we pretty much do urinalysis on almost everybody that walks in the office, and you suddenly see sugar in the urine, that they're positive for glucose. And you don't see diabetes on their lab sheet or their history, and you ask them, hey, do you have diabetes? Any history of it? And they go, oh, no. Well, so you send them off to their primary, and they go ahead and they run the test. Next time you see them, they're like, wow, you guys nailed it. I had diabetes. I didn't know it. So it can be that early detection, and it's such a simple test to do that. It's also used to help monitor and track disease processes in response to treatments. Great screening tool. We know it's done for employment physicals and things like that, where they're searching for areas that could be a concern, like blood in the urine, etc. And can also aid in differentiating certain diagnoses. Now, you may be surprised how far back urine analysis goes. It actually goes back pretty far. For a matter of fact, if we all got in our time machine, yes, we'd have to go all the way back to the Egyptians, 1550 BC. I've done a few talks where I've looked at this Ebers papyrus. It's kind of interesting. It's an ancient Egyptian medical document that documents all sorts of how much medical stuff they were doing back then. And it contains urine-related diagnoses. So that's the furthest back I could track. Maybe somebody in the audience has heard of something even further back than 1550 BC. Let me know. You can put it in the comments section. And Hippocrates, the father of medicine, he's also one of those that did a lot of extensive writings about the diagnostic properties of urine. So recognized even back then. Now, I found this interesting in my research. In the Middle Ages, a group of physicians were called uroscopists, and they were specialized in interpreting urine, smell, color, sediment to diagnose urinary problems. So it was even recognized back then, early specialists. Maybe a precursor to our urologist. What do you think? During the Renaissance, because of the improvements in glass blowing technology, etc., they were able to make a lot of specific instruments that helped to get better results for more accurate urinalysis results due to this glass blowing specific containers. Now, it wasn't until the late 19th century, early 20th centuries, the 1890s, early 1900s, that they came up with the first specific urine specific gravity test, and then also identifying things like glucose and proteins. So at its heart, a lot of what we look at now isn't all that old. So what is urine? What's this magic juice that we're checking out? Well, as we know, the kidneys are the filters for the bloodstream that gets all that impurity out. It's then produced urine that goes down the ureters into the bladder, and then the bladder stores that urine, and it's eventually excreted out once you go to the bathroom. So it's the processing of getting rid of all those unnecessary chemicals. At its key element, about 95% of it's just plain old water. So it's also a balance for getting fluid balance in our system. Now, some of the chemicals that we find in urine are things like urea, which is from breakdown of proteins in the body, creatinine, but I'm going to be stumbling over all these words this early. It's a waste product generated by the muscles, so that makes sense. Ammonia is a small molecule that's from nitrogen that's formed during the breakdown of amino acids. So very common to find ammonia in the urine. Uric acid, we all think about what we do to prevent uric acid stone. We tell them to lay off the red meat because of the breakdown of purines. And actually, interesting point, it's not just red meats. Just about we always say anything that will ever walk the earth is probably a producer of purines. So almost all meat. Sorry, chicken. Sorry, pork. You have purines also. We're going to find a whole bunch of salt and ions in our urines, the various electrolytes, the common stuff that we're always looking at: potassium, sodium, chloride, calcium, magnesium. And we see a bunch of organic acids and bases, things like citric acid, oxalic acid, hippuric acid. As a matter of fact, I was kind of curious myself how many chemicals are actually inside of urine. And so I asked ChatGPT, I'm the computer guy, how many different chemicals can we find in human urine? And here's what I found. So it's quite a list. For a matter of fact, it almost looks like the periodic chart of elements. We can see all sorts of crazy things in our urine samples, including gold. Maybe that's why our urine is yellow. Anyway, so let's get on to our urine assessment. As we mentioned, those uroscopists, they were using their basic senses of vision and smell to assess urine. And even today, we still use those two things, our eyes and our nose, to do the preliminary check of urine. You can just get a lot of information just from that. So physical exam of urine, we always have to look at the color, the clarity, and then we note the odor. Even the automated machines that we have in the office, I don't know if there's any out there that actually are accurate for looking at the color of urine and the clarity. Most of that is hand put in by the person who's running the sample. So let's start out with the eyeballs, our color. What does the color of urine tell us? And at its very basic, normal urine should be a pale yellow to amber color, kind of what we see there. And that's can vary as to how yellow and how amber it is based on hydration levels. So the more concentrated, the darker the urine is going to be, the less concentrated, the lighter it's going to be. So it does give us, just looking at the urine color itself, a certain amount of information about whether the patient's dehydrated or not. Now, sometimes you can see actually urine where it's clear. There's like no color to it. And that can be a real problem because some patients out there are drinking so much water that they can actually, there's something called water intoxication where, you can actually die from it by diluting your electrolytes so much by drinking too much water. So it's good to drink water, but don't go crazy because it can happen. So if you start seeing your urine having no color to it, watch out. You may be overhydrated. Again, the eyeballs will tell all. Now, as urine gets darker, as I mentioned, dark yellow to amber color, now we start thinking patients that might be dehydrated for some reason. They're not drinking enough water, period, or maybe they've had some issues that cause dehydration. Red and pink urine, we kind of know that's the warning sign that there might be a urinary tract infection, something causing blood in the urine, a kidney stone, a tumor. We know that red's going to be a warning sign that we need to look into that. Now, there are certain medications that can cause urine to temporarily take on a reddish color. And I'd be interested, put this in the comments if those that are watching. Have you ever had a patient tell you that they ate a lot of beets and that's why their urine was red. I always kind of thought, well, that's kind of, somebody just trying to come up with a coping mechanism to explain away their hematuria. But it's actually true. Beets can affect the urine. There's something called beeturia. You may have heard it here first now. But there's something called the beta cyanin pigment, which is found in beets. And actually at enough of a level, it can cause some color to the urine. So I guess maybe some of those patients might have been right. I still think a lot of them had hematuria because you won't find red blood cells if you're eating beets. Orange can be sometimes be seen in urine, especially if people are, trying to eat a lot of carrots for that great vision that you get, or they just like the carrots. But sometimes it could be a sign of liver or bile duct issues. And thanks, Susie. I saw that one come through. You saw it too. I figured I wasn't the only one to hear that from patients. Now, brown or dark brown urine, that could be a sign of severe dehydration, potentially liver or kidney disorders. And we know that, blood as it sits around can do that. But this one I found interesting. Foods like fava beans can actually color the urine a dark brown color. Now, every time I hear the word fava bean, I think of Silence of the Lamb.
I ate his liver with some fava beans and a nice Chianti.
Sorry, can't help it. I got to throw that one in there. But yeah, other things, as I said, hepatitis, cirrhosis, and kidney injury, anything that could cause old blood can make a brown color to the blood. Rhabdomyolysis and porphyria and hemochromatosis can also cause that dark brown urine. So I've seen a few patients with hemochromatosis where the body doesn't get rid of the iron and they have to have those phlebitic episodes where they draw off blood to get rid of that iron. Also, certain medications can certainly affect the color of urine. And a lot of those over-the-counter medicines can cause urine to be blue, green, that nice pyridium, yellow, red, whatever that color is. But the big thing is, if you're going to have a patient use that, make sure you warn them it's going to happen, because some patients will freak out when they see their urine change colors and they don't know they don't expect it. So keep that in mind. A lot of these medications can affect the color of urine. The ones that we use commonly for the antispasmodics, they're notorious for it. Also, how clear it is. We mentioned that clarity matters. So if urine should be clear, even if it's dark, it should still be clear. But if it's cloudy or turbid, now we have to wonder if there's something causing mucus or white cell production or bacteria, things that we start thinking infection right away. Never saw this in my 40 years in urology, but I did read about it. Black urine, extremely rare condition, may indicate melanoma, alkapatonuria, or consumption of certain foods or medications, always, right? But the big thing was, if you observe black urine, seek medical attention immediately. I think that might get a few people into their doctor. But hey, and again, in the comments, if you've ever seen it, let me know. I'd be interested. Again, 40 years, I've never seen it, but melanoma could be a risk. So keep an eye out if it happens. Yes, we do use our nose for urinalysis. I can tell you, when I first started, we had one of the oldest urologists in our group. And I say old, I mean, was probably in his 50s, right? But back when I started, I was in my late 20s. So it was old to me. He would pick up the cup and, yeah, go run this one. It's, it needs the culture. And I'm like, this is crazy. How do you diagnose? I mean, I know he's an experienced urologist, but he's diagnosing with his nose. Well, I can tell you that after looking at or smelling and processing so many urinalysis samples, you get distinctive odors that you'll pick up immediately with your nose, and you'll be able to tell. And now I'm that old guy who, this one's probably got an infection. So use all the sense that you have. Ammonia is a normal odor that we should pick up in urine. Remember, it's the breakdown of the nitrogens. However, if it's excessively strong, it could be dehydration. Again, urinary tract infections could cause that. There's certain things in bacteria that break down the nitrates that are normally found in urine to make nitrites, which can then convert over to ammonia. So that also causes that increase. We mentioned diabetes can be picked up in urines. I hate to tell you, this is a true fact I read back before the tests were available to test urine with a test strip. They used to taste urine because if it was sweet tasting, they could detect that somebody might have diabetes. Now, no recommendation for that, by the way, but that was a fact back in those probably Ebers papyrus. They were checking that out. But sweet or fruity smell can be often noticed in the urine on diabetics. And I think that probably most of us that have been in this have picked up that odor. Fishy, I mean, kind of that foul smelling, like a bad fish type thing is real common with this description for patients that have a urinary tract infection. You can almost tell from the odor that something's wrong. Now, here's an interesting one: sulfur or rotten egg smell. So asparagus can cause this to happen in the urine. It produces hydrogen sulfide, which has that rotten egg smell. Now, what's interesting about asparagus, and I don't know if everybody knows this, but it relies on a genetic factor in order to smell the asparagus in your urine, and not everybody has that gene. And the reason I know about that is because I have it. I can tell if somebody's had asparagus recently, or if I've had asparagus, I can smell it in my urine. But my wife can't. She can't smell it, and she thought it was just a bunch of I'm making it up, right? And I said, no, actually you can. Now, to my own mistake, I thought that the genetics was that people that had the gene converted to the hydrogen sulfide. And I was wrong. Actually, it affects your ability to smell that particular molecule. So if you're lacking it, you just don't smell it ever. And if you have it, you will. So it's interesting. I always like to say there's something new you learn whenever you give a talk. And this was one of the things I found out that was a misconception of my own. So I thought it was part of the conversion. It's actually the ability to smell. So I always like to drag that in front of my wife, that I have a little more sense than her. And thank you, Andrea. I agree. Some people wish they didn't have that ability. I joke with, for those of you that have grandkids out there, some of these genetic things that we pass on to our families will then travel, down the line. And so we always like to kid about superpowers. And from my side of the family, we have the ability to raise one eyebrow and not both at the same time. Now, my wife can't do it. And some of my grandkids can, some can't. So we always kid the ones that got the superpower can raise that one eyebrow. And it also goes typically with flaring your nostrils, wiggling your ears, all that kind of crazy things. And probably smelling the asparagus in your urine. So did you pass on superpowers to your grandkids? Maple syrup. Well, I just ruined pancakes this morning for everybody. But yes, a maple syrup odor in urine is associated with a rare genetic condition known as maple syrup urine disease. This interferes with the metabolism of certain amino acids. I have to say I've never seen it. Curious if anybody else there has seen it, but again, sorry if I ruined your breakfast. And this last one, fecal odor. So most of us probably know what this is from, and I'm going to throw this out to the audience that's watching live. What's the one thing when you have fecal odor in the urine that you want to look for? And what's the key sign of that happening? A question you want to ask every patient that you think might have a fistula, a connection between their bowel and bladder, because that's what gets the fecal odor into the urine, is an actual connection between the bowel and the bladder. So what question can you ask? And while I'm talking about this, go ahead and throw those in, and Andrea will put them up on screen if you guys figure it out. But as I mentioned, so sometimes there can be a condition where the bowel and the bladder become attached at one point, and always you can see it almost floating in the urine. You has that smell, and I always kind of like those because those are kind of cool things to, you bring it up and hey, doc, look what this guy, he's probably got a fistula. And most of the time we're going to take a look in their bladder, because these fistulas can open and close. They can seal off and then suddenly open, and you want to catch it when it's open, obviously. So if there's stool in that urine, that's the best time to scope them. So we go in there and do a cystoscopy, and you have something called the toothpaste sign. And the reason it's called that, it looks like somebody squeezing toothpaste through the bladder wall. You see this little hole with this strip of like toothpaste looking stuff. That's the actual bowel content being squeezed through into the bladder. And the best part about that is that those are the patients that we refer off. So, you get to see the cool disease, diagnose it, but I don't have to write up the surgical papers for a surgery for this patient, because they go off to general surgery for repair. Andrea is absolutely right. So the key thing you always want to ask a patient, have you ever had air in your urine? You started to urinate and all of a sudden you passed air instead of urine. And almost universally, they've all had that, because the bowel content will produce gas, and then that gas has to get out. We know that normally, unless you, in some reason, put air in their bladder, it's not going to happen. So, hey, go to the top of the class. Thanks to our experts. I got to keep my finger buttons off of that other one. So this is a remind me that I think that we always need to talk about safety. And OSHA is our big organization that protects us, the worker, against occupational exposure to infectious diseases. And urine does have that potential. Now, back in the 80s, universal precautions came out, and in the 96, it was updated to standard precautions. The reason I bring that up is I've taught a lot of people in my office about taking care of their safety when dealing with stuff with patients. And one of the things was, how do you handle urine? Can you handle it? Can you hold it in your hand, or do you have to have a glove on? And back before 96, I can tell you that according to OSHA guidelines, you did not need to wear a glove. So if they were comfortable and wanted to just hold it, as long as there was no blood visible, you could do that. Now, I can tell you that that's not the case anymore, because the standard precautions have taken over, and urine, you can see from this checklist all these things that have been added to that as a precaution. And, quite frankly, you really don't know if it's got blood, and if it's microscopic, you wouldn't necessarily see it. So always wear gloves. You want to have full protection on whenever you're dealing with anything that's a bodily fluid. So definitely gloves. If you're centrifuging urine where you're going to be spinning it, I think it's a good idea to have goggles on, so that if there was ever some mishap, you're not going to get it into your eyes. I can tell you, back when I started, I used to wear contacts before I was in urology. Once I got into urology, I switched to glasses pretty quick, just because it offered that protection against splashing. Now, what about the garbage? The little cup that you get at the end of the urine. Can you throw that in the normal garbage? Does it have to go into the safety waste? The bio bags. That's expensive stuff to take out. The garbage is far cheaper than medical waste. So OSHA does say that as long as it's not contaminated with blood, it can go into a normal garbage can. You can dump it down the sink. There's no problem with that. Also, really important is to get a good result on your urine, you need to have a good urine sample. And this is really important. And a lot of people, I think, don't stress enough to patients about the proper way to collect a sample. We have pictures in the bathrooms of how to do this. And we always explain to patients, we want a fresh urine. A lot of patients will bring a urine from home. I mean, that's been sitting for hours. Who knows what it's grown. So if they can't void, we'll look at it, but we always want them to give us a fresh urine. Should be the midstream. We're looking at the first part of the stream is urethral urine. We want the bladder urine. So it should be a midstream. If they're a male and they're not circumcised, they should strip back the foreskin. They should wash around the head of the penis to get the best sample. If they're a female, again, the same thing. They need to spread the labia, clean around the urethra. Again, catch the midstream and keep the labia spread while you're going and giving the sample. So good sample will give you a much better result than a bad sample, which could give some false information. After a while, we get a bunch of these urines sitting on our desk, and one urine looks the same to me after a while. So always be sure to put a label on your urines so we know whose is whose. Also, sometimes we'll collect two samples, the first sample, that urethral sample, and the second sample, the midstream. And the reason we get two samples is the first sample can often lead to diagnoses such as STIs, or sexually transmitted infections, because chlamydia, for instance, will have this characteristic look of kind of a stringy looking thing in the first urine sample. The second one usually will be clear, but the first one will have it. So we'll throw that up on the scope instead. So sometimes you do want to get both, the first and the second. Label them 1 and 2 so you know, and you tell the patient, you know, I want the first part in this of the stream in the first cup and the rest of the stream in the second cup. I did give a patient once the cup labeled 1 and 2, and the first cup came back urine, the second cup, you can guess it, came back stool. So be careful that you really explain it. Our strips tests are all done by these dipsticks. They've been around for a long time, and before the automated machine was available, we just hand dipped it and read it. So we're going to talk about the manual test. How do you do that? Well, number one thing, you have to make sure you have a watch or a clock or something that can tell seconds so that you can time it, because some of these tests are very crucial to be read at a certain time. And so here's a test strip that I can show you that we would typically test. Now we use the 10, so the ascorbate is not one of our tests, but you dip it and then you start your clock. At glucose can be read at 30, bilirubin at 30, ketones are 40, specific gravity at 45, blood at 60, pH at 60, protein at 60, urobilinogens at 60, nitrite 60, and leukocytes take a full 2 minutes to develop. So if you were to just dip it and glance at it, you could get a misreading if you don't let it develop long enough. And it's really pretty simple, as you see at this picture on the left, to just kind of compare the strip to the bottle and come up with the numbers based on the color change. And our eyes are very sensitive to color changes, so we picked that up pretty good. Now, most of us, I shouldn't say most of us, I think a lot of us have these automated tests, and they really make life super easy. And I'm going to talk to you about how, in case you don't have one, how it's done and how it should be done. And that goes right here.
A quick test is a convenient way to run a test on the analyzer without having to enter additional data such as operator ID and patient information. To begin the quick strip test, have the test strip, urine sample, and a paper towel ready. From the main select screen, touch Strip Test to access the Prepare Test screen. Verify that the test table inset is positioned with the reagent strip holder facing upward. Touch the Start button. The Prepare Test screen prompts you through the preparation steps, which must be completed within 8 seconds. Dip the reagent strip into the sample, wetting all the pads. Be careful not to dip the automatic identification band or color band into the urine sample. Remove the strip immediately from the sample by dragging the edge against the side of the sample container. Touch the edge of the strip against a paper towel to blot any excess urine. With the test pads facing up, place the reagent strip in the channel of the table and slide it to the end. At the end of the 8-second countdown, the analyzer automatically pulls in the test table. The analyzer performs an automatic calibration each time a test is run. Be careful not to move or bump the test table while the instrument is calibrating. Once calibration is completed, the screen displays a countdown of the time remaining in analyzing strip test results. When analysis is completed, the test strip is ejected and the results can be reviewed on screen or on a printout. If the analyzer has been set up to print the results automatically, the printing screen displays until the printout is completed. If the print option has not been enabled, the results screen appears. Additional results information such as date, time, and type of test can be viewed by pressing the More button. If a printed copy is needed, it can be obtained manually by pressing Print. Test results remain on screen for 2 minutes. After that time, the display returns to the main Select menu. Touch Done to complete the test and return to the main Select screen. Remove the used test strip from the analyzer. Dispose of the test strip and report results according to the procedures specified at your facility.
All right. So one thing I did forget when I mentioned the manual test is the same thing that you saw them do with this automated test. After you dip it, you touch it to the side of a paper towel. to get any excess urine off of the strip. So you don't want it dripping urine as you're holding it up or when you put it on the automated test. If you're not doing the automated test or don't have one in your office, check with your local company that's selling you the test strips, because I can tell you that I think all the machines that I bought were bought from a special where you go and you purchase so many test strips and they throw in the machine for nothing or some minimal cost. So that's a good way to get the machine. So just buy, and I think at one time it was like 10 of the bottles of strip test. So it's really a lot simpler to run. It's as accurate as looking at it with your eye. So I recommend using the automated test system. Now they were talking about this quick test. I don't recommend doing that because you may as well get the printout right away. So we always put the quick test is skipping putting the patient's information in there. We always put in the patient's information and an identifying number, and then go ahead and get that printout. We scan it and put it into our EMR. We also enter it into our EMR with the numbers. I think there's some of these that can actually be incorporated to send that directly to your EMR, which is even sweeter. So if you have any of those tests in your office, great. Now, so what does this urinalysis machine tell us? So this is the information that we get. Number one, on the bottom, glucose. Presence of glucose could indicate diabetes. As I told you in that case study where patients come in and we pick it up periodically on patients who don't know they're diabetic. So always checking for sugar is a good idea. Bilirubin could suggest liver or biliary problems. Ketones, again, with diabetes, diabetic ketoacidosis. Specific gravity. So, and then you can see on the left here, the numbers, what the actual numbers should be, either negative, 0. Specific gravity is 1.0 is the specific gravity of water. So basically urine is about the same as water. Of course, if it's more concentrated, the specific gravity will change, or less concentrated, it'll change. I don't think it'll be less than 1. Blood, that's a key one, hematuria. So again, it marks off different, it starts to turn more green as it gets to have more and more concentration of blood. However, one of the things about the hematuria test is it's looking at particles that are produced, myoglobin and something else, not RBCs. So it's not predicting RBCs. So pH, again, if you're familiar with pH, that's how acidy or non-acidy basic something is. Water is 7.0. So if it's a lower number, it means it's acidic. So urine, normal urine is about 6. So it means it's slightly acidic to basic. Certain infections can cause urines to go to 8, 9 because they change the pH of the urine. So it's better for producing crystals to protect them. Protein in the urine. The kidneys are the filter for proteins. They're to keep us from losing those, so they shouldn't be shed in the urine. So if we saw protein in the urine, we could be concerned about some kidney disease. Urobilinogen, again, is a liver test. And the top two, leukocytes and nitrites, are tests that patients can actually get a test strip for just those that have recurrent infections as an indicator that there might be a UTI. Indicator because there are some times that these are not true or not correct. So, for instance, leukocytes and nitrites both being positive is a pretty good indicator that there's probably an infection. Leukocytes are white blood cells. But if you're doing BCG on a patient, that's going to cause white blood cells in the urine. So the BCG is causing the white blood cells and not an abnormality like a urinary tract infection. So by itself, it's a good test, but not a great test. That's where that microscope's going to come in handy. So you can confirm some of this stuff. Nitrites are, again, nitrate is normally produced in the urine, but bacteria can convert those to nitrites. So that, again, is suggestive of a urinary tract infection if that's positive. So great screening tool. Can't argue anything about urinalysis as far as being a great screening tool, but it can be made better. And that's why you're going to come back next week, because next week I'm going to take you into the world of microscopy, where I'm going to talk about, it's a little more advanced, but I think that it's easy enough to do. I've been doing almost my whole career microscopy. So we did microscopic urine analysis in the office. And when you bill for those, there's actually 2 different billing codes. So there's an automated which is the dipstick test, and then there's with or without microscopy. So if you're doing microscopy, you can bill for that higher code as long as you're performing that. With that, I am done with my talk. So I'm going to go ahead and bring in our experts here. Welcome back, experts. And this is the time that anybody has any questions from the audience. This is a great time to place those into the comment box. And
Vic, we actually had a comment that I missed on the asparagus discussion.
okay.
So it sounds like they will test for it on the 23andMe genetic testing.
Oh, wow.
Yeah.
That's fun.
I guess it's probably cheaper just to eat asparagus and find out.
Exactly. We do have some questions coming through. There was one question here from Teresa, and it sounds like the question is that she receives a lot of referrals from primary care doctors' offices.
Let's bring that one up so we have it up here. Yeah, this was one that, again, as I said, you can send these in advance. So I put it in here for her. But yeah, go ahead.
So it sounds like she's receiving a lot of referrals from primary care doctors' offices saying that the patient has microscopic hematuria with just the dipstick being positive. So when we're talking about a dipstick, that's the screening test in the video that Vic highlighted. And I always tell my patients that's a screening tool. It's not always 100% correct. And so we always want to send it to the lab so that they can look at it under the microscope to confirm whether or not there's actually microscopic blood in the urine. So I see that as well. So it's just about re-educating primary care providers and the patient that it is not considered microscopic hematuria unless you have a micro analysis confirming that there's greater than 3 red blood cells per high-powered field.
Exactly.
Recheck it. I'll usually recheck it in the office. If there's anything coming up on the dipstick indicating hematuria, then you send it for the microscopic analysis. So that's usually the discussion, how it goes in the clinic with the patients.
I think her one concern that she had pointed out, which is pretty valid, is the controversy of, do you work this up? Do you work up a positive dipstick? And the AUA, their stance is if it's just a positive dipstick, you don't work it up.
Correct. Yeah. And in fact, there's some great resources out there. The American Urological Association has their hematuria guidelines that you can easily find. Yes. Thanks, Vic.
See, it's nice when you send the questions in advance because we prep for it. And Therese, great question. I hope you get to see your answer. But yeah, as you said, there's this great algorithm for who to work up and who not to work up. And I'm just gonna make it a little bigger so you can kind of see. And I think I'm gonna actually take us out of it and bring it up. Whoops, no, that didn't work. That worked. Just make this the full screen. So besides the test, as Andrea said, we look for the blood under the microscope, look to see if there's any blood cells. If there's no RBCs, that doesn't really require a workup. But the other thing that's interesting about the algorithm is they look at the risk factors. So somebody at low risk, such as age being one of the factors, smoker or non-smoker being a factor, and what quantity of RBCs are being seen. Now we see low risk 3 to 10 RBCs per high field. So we'll talk about what that means on next week's talk with microscopy. But compared to intermediate risk, in which there's 11 to 25. So obviously more blood cells being seen under the scope. And then again, high risk with actually history of gross hematuria. So I think that this is really a nice algorithm. Recommend that you go to the website and download it. Is a nice way to guide yourself through what needs to be worked up. And I like in this low risk area where they say it's a shared decision making. Repeat urinalysis obviously makes sense. You're going to want to make sure that you're rechecking the urinalysis. Considering repeat urinalysis at 12 months, and if still nothing, then maybe you can let them go. But it was a great question. So I'm always glad when I can bring that in, have the answer with the proper quote. All right, go ahead. Nope, you must have your must be muted.
Thank you. Rookie mistake. We have a question from Susie. On the urine analysis, you said something about hematuria on dipstick that's not caused by red blood cells. Please explain.
So the sensitivity on the stick is for products of blood, myoglobin. I'm murdering this in the morning, but basically, it doesn't look for RBCs. It looks for products that are produced by blood in the urine, and that's why it's can be false positives. It can also, there are some chemicals and things that can cause false positives on that test. So got to be confirmed by microscopy. There's no way around it. And again, it's next week I'll hopefully convince everybody to get a nice microscope for your office. They're not all that expensive, and hey, there's a lot of fun you can have looking at things under the scope.
Yeah, I'll also bring up, guys, something that I see happen rather often. So you mentioned the importance of a good collection of a urine specimen. Can't stress that enough. So say you're talking about blood in the urine, right? Add that with perhaps the poor education on female anatomy. Sometimes if, women are on their menstrual period and don't do a good enough of a collection, you can also see that blood, kind of put two and two together there. See that more often than what you would think. So, very important to make sure that you do a clean catch.
Yeah.
Good point, Liz. I worked with a urologist in the past who would always look at the cup to see if it was wet on the outside. He said he can't be a clean catch if it's not wet on the outside with urine. So he would look.
That is funny.
Yeah. The other thing, and it kind of goes along with microscopy, is, and I'll kind of talk about that more next week, but if you're getting a female collected sample and you see a lot of these large epithelial cells, which are typically vaginal epithelial cells, then you know that they're washing that down from the collection, so that may not be a really clean sample. So if you see that and bacteria, most of the time our guys would say, hey, let's get a cat sample so we're sure.
Yeah. I also wanted to highlight for the audience on the microscopic hematuria guidelines. They actually have, AUA has a really nice app that you can use. I use it every day in practice, and it has all the guidelines outlined. I think I access the AUA hematuria guidelines so many times, I have them memorized now.
Do you have a web address for that, or?
If you just search on your apps, AUA, which stands for the American Urological Association Guidelines, you can just download the app right there from your phone. Yeah, it's very easy to understand, and the algorithm's really great to use in clinic as well. We have another question here. I'm going to pull that up. One provider insists on clean catch for micro, no cath samples. What are your thoughts on that?
Interesting. Not sure why you wouldn't want a cath sample.
I've heard some people in the past say that maybe just the act of catheterizing the patient could cause some urethral trauma, causing some hematuria. I don't know if there's anyone who's actually studied it. I guess that's for any of our students or academics out there, that'd be a great place to maybe look at the research and see, are we doing the right thing really by doing a cath sample or not?
Yeah. And I would agree. I think that, it should be a last resort that you'd ever catheterize a patient, especially if you're concerned that they're infected too, with infection. Again, I'm not sure. I don't have a good answer. I'm kind of thinking that if it was a female patient and I saw, large epithelial cells along with the bacteria, that I might consider that was contaminated, and just based on that, try to get a new collection. But be interesting if you have follow up on that, Janelle, let me know, because not sure why that was. Maybe ask whoever that provider was.
Yeah, I have heard that reasoning as well, Andrea, before. But then likewise, Vic, especially when we're looking at potential recurrent infections, doing a catheterized sample for females most likely, again, anatomy, is rather common. But then again, you're looking at more than blood also.
Yeah.
So
I think that's another future talk that we should have somebody, address is UTI. Are we underdiagnosing it? Are we overdiagnosing it? I think that there's a good argument for both sides of that. I think that, we all have had that patient that comes in complaining, I got a urinary tract infection, I need antibiotics. And they don't. They have, overactive bladder or some other disorders, could be a kidney stone, all sorts of things that cause the same symptoms to the patient that aren't really an infection. So we have to be careful that we're not overtreating or missing something from what our results are.
Absolutely. We were talking about patients who are eating beets that can cause visual blood in the urine. So I actually looked it up. So the beets, rhubarb, and berries. I recently heard of some strange fruit. I suppose like dragon fruit or something really weird that actually caused the urine to appear red as well. I don't know if anyone has any strange fruits that they've encountered or any other foods that can cause pink urine. Please put that in the comment box. We do have another comment here. She says some damage to the urethra, not as accurate. Other providers in the office do not do this.
Yeah, it's a good rationale. I think that we always talk about how much is evidence-based that we do and how much is just plain old dogma. And, I think this falls under the plain old dogma. I don't know that there's any great evidence that I've read as far as what you need to do.
Yeah.
But again, that would be a great subject to kind of look at in the future about UTIs. We do have some talks coming up in January with Diane Newman from, she spoke for us before. She's well-versed, and there's some studies they're looking at that have to do with catheters. And, she's a good one to kind of pick her brain on stuff like that. So I'll have to remember to do that when she comes on our show again.
Absolutely. Apparently, Oprah told a story that she had red urine from eating beets as well. Very interesting. Even celebrities.
There you go. When Oprah has red urine, then we know it's okay. I was surprised because the first time I heard it, I'm like, the patient's nuts. They're typical, right? You try to come up with any good explanation besides I've got, possibly cancer, right? So, and it's like, oh no, I had a lot of beets. No,
yeah,
but yeah. So
just out of curiosity for you guys and anybody watching, what is the strangest urine you've seen?
Ooh. Yeah, that's a good one. Strangest urine.
I mean, there's various, right? We talked about
Yeah.
glucose in the urine. I've seen it where it's sticky, literally, where you pull that, your dipstick and it's stringy. Seen a very bad fungal infection where urine looked like milk and it would not process in your Clinitec. Patient actually needed ureteral stents because it was causing hydro bilaterally. The list goes on. Lots of different strange urines, but I'm interested to hear what anybody else has to say.
So I've had, I don't know if it's strange, but I think it's one that we may not always think about, especially nowadays, probably don't see it as much, but in the older days with patients who had TERPs done, a lot of times the urine would have kind of that cloudiness to it. And what it was it was the retrograde ejaculation. So they recently had sex and the semen just backed up into their bladder. So in their urine, they had urine and semen mixed, and it kind of this milky looking substance in there.
Yep. Deborah said the weirdest urine she's seen, it was in a drainage bag and the purple bag syndrome.
Yeah. That's a real mystery. What happens. Those are, if you haven't experienced it with a patient, you'll never forget it because that urine just reeks. And it's usually the organ. I think the main organism that does it is Proteus. And it's something that it causes that purple color to the bag. It's written up purple bag syndrome. And it's really tough. And a lot of times just getting the patient off of that bacteria into something friendly like an E. coli makes the huge difference, because E. coli doesn't produce that smelly purple foul bag. Not only that, but it also, if you see that, check the pH of the urine. I guarantee it's going to be a high number. It's a very basic urine. And that's that protection that the bacteria is trying to do by forming crystals. So that's why those are the catheters that Todd Thompson talked about, that you dissect and you see all this crystal formation inside of it. So it all goes along with that whole purple bag syndrome. But hey, that was a great point to bring out.
Yeah. Dark, we're talking about all the strange urines that we've seen. So dark brown urine a couple of times and thick. Patient was diagnosed with bladder cancer.
Yeah.
Thanks for sharing that. Yeah, that's definitely a concern.
I
missed one
from the audience.
We also have Elizabeth saw urine that looked like milk. Patient was admitted in acute kidney failure and recovered thankfully. Yeah. I've seen, the curdled milk urine as well. Yeah, it's definitely a concern.
Early on in my nursing career, there is every summer here in Iowa, there is a biking event called RAGBRAI. So I was very flat. And, folks ride all through the state. They come from all over. And, biking lots and lots of miles, probably not hydrating appropriately. As a young nurse, saw quite a few patients with rhabdomyolysis, and that gross dark urine as well. So hydration is important, but very interesting.
Absolutely. Well, this was great. I really love the comments, audience. It was great to have your feedback. And as always, if you have a question, when you see the topics coming in through the newsletter, you're like, hey, this is the time I want to ask the experts this. That's what you wanted to go and put in through our contact us, because then we get a little chance to do some research on those things and get you the real best answers. So it's been great. You guys have done a great job. I'm going to switch over here to a couple clean up things here for you. So as a reminder, next week we have Peeking Inside the World of Urinalysis Part 2.
Urine microscopy is a valuable diagnostic tool to examine the cellular and structural components of a patient's urine sample. This analysis provides critical insights into the health of the urinary system. It can aid in the diagnosis and monitoring of various medical conditions. During urine microscopy, a urine sample is placed under a microscope, allowing the observation of elements such as red blood cells, white blood cells, epithelial cells, crystals, and casts. Abnormalities in these components can indicate a range of issues, from urinary tract infections and kidney diseases to metabolic disorders and renal stones. Join UroNurse.com as we go peeking into the world of urinalysis with the aid of the microscope.
All right. Looking forward to that for next week. Hey, in 2 weeks, folks, we're going to have our after Thanksgiving show. Thanksgiving will be that Thursday. So on that Saturday, if you haven't overdone yourself in turkey and too much shopping on Friday, and you got nothing you wanted else to do but ask the experts anything you want to ask us. Our experts will be available to do a Q&A show. So we don't have an actual set topic. We're going to just take questions from you, the audience. So feel free to submit those. Again, as I mentioned, you can always submit the questions anytime you want by going on to our Contact Us. Ask us anything. We'll tell you the answers to everything. Want to know what car to buy? But if you have a urology question, we'll really dig ourselves into that. So we're looking forward to that show. It's going to be a little different. We'll see how it is. So you're going to drive the show. Your questions will drive it. More questions you ask up till that 1 hour limit, we'll take them. Otherwise, if we don't have a lot of questions, hey, we'll just go enjoy some more turkey. Panelists, couldn't do this without you. Really enjoyed having you on board. Oh, great presentation. Thanks. I'm glad you liked it. I enjoyed doing it. Thank you also. It's like I said, if you're ever interested in being a presenter for UroNurse, don't hesitate to reach out to me for that either, because I learn a lot when I do presentations, and that's one of the reasons I like to give them, just because I always come up with new ideas. So hope you enjoy next week's just as well. All right, with that, we'll see everybody next week, and enjoy the rest of your weekend.